Welcome back to the channel. Today I am going to talk about toxicology emergencies. Toxicology emergencies are unique in emergency medicine because many of them can be identified through rapid visual pattern recognition. These patterns, known as toxidromes, are so distinct that you can often make a working diagnosis within 10 seconds of seeing the patient. In many cases, this early recognition is crucial because the disease progresses faster than laboratory tests can return. The priority is always airway, breathing, and circulation. And antidotes, when available, should be administered early before confirmatory results are even ready. Opioid toxicity is one of the most recognizable toxidromes. These patients are characteristically drowsy or unresponsive, breathing slowly and shallowly, and have pinpoint pupils. They often appear cyanotic and cold, because the main danger is hypoventilation leading to hypoxia. The first step is ventilatory support, usually with bag valve mask ventilation. Naloxone can be titrated carefully to restore adequate breathing without precipitating severe withdrawal, and close observation is important because its effect may wear off while the ingested opioid continues acting. Second, sympathomimetic toxicity presents very differently. These patients look as if they have been running a marathon. Sweaty, intensely agitated, tachycardic, and hypertensive, often with dilated pupils. Their body temperature may be significantly elevated due to excessive adrenergic activity. Cocaine, amphetamines, methamphetamine, and MDMA are common culprits. The major complications include rhabdomyolysis and life-threatening arrhythmias. Benzodiazepines are the mainstay of treatment because they blunt the sympathetic surge, reduce agitation, and help control hyperthermia. Cooling measures may be required, and pure beta blockers should be avoided because they can worsen vasoconstriction. Anticholinergic toxicity produces a dramatically different picture. These patients are hot but dry, flushed, delirious, and often profoundly disoriented. Their pupils are fully dilated, their skin lacks sweating, they cannot urinate, and bowel sounds are markedly reduced. Common causes include antihistamines, tricyclic antidepressants, atropine, and certain toxic plants. Complications include seizures and cardiac arrhythmias, especially with TCA overdoses. Most of the time, treatment is supportive with benzodiazepines for agitation. Physostigmine may reverse pure anticholinergic delirium, but it must be used with extreme caution and only when cardiac monitoring confirms that there is no underlying risk of arrhythmias. In contrast, cholinergic toxicity produces a patient who is profoundly wet, covered in secretions from head to toe. They salivate, sweat, tear excessively, vomit, urinate, and pass diarrhea uncontrollably. Bronchuria and bronchospasm threaten the airway, and these patients often have bradycardia and pinpoint pupils. Muscle fasciculations are also common. Organophosphate insecticides, carbamate pesticides, and nerve agents are the usual causes. The most important step is airway management, especially suctioning to clear the overwhelming secretions. Atropine is given in repeated doses until breathing improves and the lungs dry. Pralidoxime is most effective when given early, and benzodiazepines are used for associated seizures. Serotonin syndrome is another rapidly identifiable toxidrome. The hallmark sign is clonus, which may be spontaneous or inducible. Patients are hyperreflexic, sweaty, hyperthermic, and agitated. They may also show tremors, tachycardia, and hypertension. Serotonin syndrome commonly occurs after combinations of serotonergic agents such as SSRI, SNRI, MAOI, tramadol, linezolid, MDMA, or cocaine. The complications include severe hyperthermia and rhabdomyolysis. Management begins with stopping the offending drugs, providing sedation using benzodiazepines, and aggressively managing temperature. Cyproheptadine can be helpful in moderate to severe cases. Beta blocker and calcium channel blocker toxicity present with a deceptively calm patient in shock. They are bradycardic, hypotensive, and lethargic, but they may not appear distressed despite poor perfusion. Certain lipophilic beta blockers like propranolol can also cause seizures, while calcium channel blocker toxicity may present with hyperglycemia due to impaired insulin release. These poisonings can rapidly progress to refractory cardiogenic shock. Treatment involves atropine, intravenous calcium, glucagon, vasopressors, and especially high-dose insulin euglycemic therapy, which improves myocardial contractility. Intravenous lipid emulsion therapy may be considered in severe cases involving lipophilic agents. Carbon monoxide poisoning can be subtle because affected patients may appear deceptively pink or flushed despite profound tissue hypoxia. Symptoms range from headache and dizziness to confusion and collapse. The key clue is the exposure history, particularly fires, faulty heaters, or situations where multiple individuals become ill simultaneously. Pulse oximetry is unreliable because it cannot distinguish between oxygen-bound and carbon monoxide-bound hemoglobin. The treatment is high-flow 100% oxygen, which hastens the dissociation of carbon monoxide from hemoglobin. Hyperbaric oxygen therapy may be needed in severe cases, especially when neurological symptoms are present or if the patient is pregnant. Methemoglobinemia produces a very distinctive scenario. The patient is cyanotic, often appearing gray or blue, but their oxygen saturation remains stubbornly around 85% regardless of how much oxygen is delivered. Arterial blood gases may show a normal partial pressure of oxygen, despite clear evidence of tissue hypoxia. Common triggers include nitrates, benzocaine, dapsone, and certain dyes. The treatment of choice is methylene blue, which rapidly restores functional hemoglobin. However, methylene blue must be avoided in patients with G6PD deficiency to prevent hemolysis. A simple way to summarize these toxidromes is by visual pattern. Pinpoint pupils with hypoventilation strongly suggest opioids. A sweaty, agitated, tachycardic patient points to sympathomimetics. A hot, dry, delirious patient with dilated pupils is likely experiencing anticholinergic toxicity. Profound secretions with bradycardia and pinpoint pupils indicate cholinergic poisoning. Clonus and hyperreflexia strongly support serotonin syndrome. A calm patient with severe bradycardic shock suggests beta blocker or calcium channel blocker overdose. A pink, hypoxic patient should raise suspicion for carbon monoxide poisoning, while a blue patient with normal arterial oxygen should prompt consideration of methemoglobinemia. That's all for this video. Thank you.